you for me.
And also it's a skeletal fracture.
And here is a quick tip for you guys. You see here that the first one
Okay, good morning, good evening, good afternoon, good evening, all members. Welcome to our 76th webinar. I am Dr. Kim from South Korea. Today, Dr. Park has a schedule, so I'm going to host this webinar. I'm really happy to meet you guys all. And well, before we start, I'll go over the housekeeping of our webinar. First of all, recordings of our webinar is not allowed at all times. As you may know, our speakers are volunteers who share their valuable knowledge and experiences to dentists from all around the world without any honorarium. Therefore, you are not allowed to record and share the webinar through any devices. If we have get the permission, the webinar will be uploaded after editing. You also could check out for our past webinars and more webinars to come. Next, certificate of attendance is given for those who have registered in advance. And if you have the permission of our speakers, you can receive your certificate by clicking on the link given on the time of registration in WEBCEPH and type in the code. A code will be given through the chat box of Zoom after the lecture, and please do not forget to receive your certificate. Attendees will be muted throughout the whole webinar, but we welcome questions. Please ask your questions by sending a private message to me through the chat box of Zoom. We will try our best to go over them. If we are ready, let us finally begin with our webinar and welcome our speaker. Today we have invited Dr. Jorge Salgado, and he will give a lecture entitled "How I Could Have Planned Surgery with WEBCEPH: Real Cases." Let me introduce our speaker before meet him. Dr. Jorge Salgado is a clinical dental orthodontist from in Madrid. He is a part of the Vitaldent Group and in 2 different clinics. He has received academic titles from Alfonso X El Sabio University as an orthodontist postgraduate. He was an aesthetic expert in Rey Juan Carlos University. A lot of our members have been excited and ready for this day. Okay. Hello, Dr. Salgado.
Hello, thank you.
Hello. It's an honor to have you here in our WEBCEPH X webinar.
No, it's an honor to be invited to these things, to these lectures. Seeing them worldwide, it's amazing. This.
Thank you. I hope that this will be a great opportunity for all of us and to you. We sincerely thank you for preparing this great webinar.
Thank you. I want to thank you that invited me, and everybody that is here, because it's really an honor. I'm really nervous, and it's the typical thing. I want to say sorry for my English. I'm sure I'm not going to say everything correctly, but I try to do my best to be understood. Okay.
Okay, thank you. And also we have a special panels for today. I'd like to introduce Dr. Cesar Colmenero Ruiz and Dr. Marina Poblacion from Spain. Hi, doctors. Okay.
Hello, hi.
Hello, hi.
Hi.
Nice to meet you. We thank you for your presence despite your busy schedule. Please agree to our members. Okay. Later after the lecture, our panelists will be having a light discussions regarding the lecture with our speaker. Okay. Okay. And thankfully, with the permission of our speakers, this lecture will be streamed in YouTube. Please like and subscribe to our YouTube channel. And then, and finally, okay, then Dr. Jorge Salgado and our panel will answer. We'll start the webinar now. If you're, so I hope that all the members have a great time through this lecture. Jorge Salgado, you can now share your screen.
Hello. I'm showing it.
Oh, no, it is not shared yet. Can you share the screen now? Because you are a host now. Probably you can share your screen by clicking the, yeah.
Now there we are.
Fine, yeah.
Well, when they offered me to do this lecture, they told me, what do you want to speak about? And I saw that everywhere they say WEBCEPH. So I tried to see what WEBCEPH was about, and it amazed me. It's a cloud tool that is better than many programs that you can have in many places. It's fast, it's intuitive, and it's I don't know. I want to show you how I could have been using this instead of what I've been using. So I put many cases, well, 13 cases, so that we can see it from the beginning to the end. I want to show how ease of use it is. Like, for example, adding a new case, a new record. It's fast, even being cloud. There we are. Click, 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 click. No, here it goes. See how fast it is. I've been wasting a lot of more time doing this thing, this same thing, but in in a computer. So it's incredible for me how fast this could be. Just clicking. This is the only case I'm going to do this. Don't worry. And the right. And there we are. I have it in the cloud, so I can go to home. I can go wherever I want. I can have it in an iPad. I can have it in a computer at home, in our clinic. For me, this is incredible. There we are, the initial cases. And then we can see with the viewer, this case, this is a girl, it's an open bite, nothing really difficult. They extracted a molar because of caries or whatever. And this is how it came to our clinic. We decided to be a monomaxillar surgery. And it's a really an easy case. I didn't want to do something very difficult for the beginning, but there we are preparing, closing the gaps and doing everything. And this is the real thing that it's amazing. And it could save me a lot of time in my life, in my short laboral life, that it's the cephalometric analysis. It's done. It's automatic. You press here and it's almost perfect. You always have to retouch everything. But we have in the clinic a computer based program that is really expensive, and it's so slow to put every point and everything that we don't use it. And it's really expensive. We paid a whole bunch of money for it. And here we go. We have the analysis done. That's all we needed. There, I think that is perfect right now. And this is the lecture was the treatment. There's a lot of things that you can do in here. The analysis. Oh, sure. I have to save it. You can see the analysis. Jarabak, Manamara, Rickett, Steiner, Tweed, Wheat. But what we are going to try is to see how the treatment, surgical orthodontic treatment, works in real life. I mean, we have this patient, it's already went to surgery years ago. We have the finished picture, the finished profile, and let's do what we were going to do to this patient. So let's come here first. Let's see what it was planned with this patient. The first thing that I have to show you is the page that we do to analyze every little thing, every aspect that we have to know about the face and about the mouth to decide what are we going to do in the surgery. As you can see here, we analyze the thirds, the upper, middle, and lower third. This, we don't use it right now because it was the measurement from the eye to the upper arch and to the lower arch, but now we measure in the CBCT. But the really good things, the things that I want to show you is we measure the upper lip and the upper lip with advance. Right now, because it was the measurement. Is there a question, something? We are here is the lip in normal, but if you pressure a little bit to the sides of the nose, you can see the difference and what it's going to do when you protrude the maxilla. We measure here and we measure there. And that's how we know that with no force, it's 14, with force, it's 15. So if we advance the maxilla, it's going to have 1 more millimeter of longitude. This is the lower, the menton, the chin, and the lower lip, so that we know that this has to be half of this. I mean, 1/3 and 2/3. So we know the relationship of the lower third if it's really nice and beautiful. But the other thing that we look here, we haven't noted anything because there was not going to be advanced. But here we note if the nose is going to get up a lot or not so much. If it's the biggest advance that the nose will allow us without getting it worse. So this patient, we didn't care about this and not even about this, but we prepared the fourth in 4 pieces. Here we say what we want to do to the lab, and they do it. But to take this, we usually, and we still do it this way. We take the cephalometric analysis and cut it. Here's the maxilla and here's the mandible, and move it. And that's exactly what this does. So let's try the difference, how this works and how it's not good, and if it works really with the real cases. The first thing, it's aligned. The photo, I was looking there to see the eye. It's so easy to use this. Here, I think that it fits. So let's start the treatment. In this patient, we are going to lower the incisor and impact go up in the posterior teeth, half and half. So it's 2 millimeters down and 2 millimeters up, like this. A little bit more. This is a change that we prepared, and the mandible is going to accompany that. It's just closing the mandible, it's not surgery here. I think includes class 1 molar. Oh, sorry. But we know it's going to be doing something like that. Maybe it will be here. Okay. This treatment, let's call it 1. And do the morph. Now we can compare 1 and 2. This is a really easy case. There's not much change, but it's the first one. We have a bigger change later. We can animate. We can superimpose to see both changes. And we can export the video so that we can show it. But I've prepared to animate. This is the finished one. And here we have the real case. So this was a really easy case, but I think that it fits perfectly. The nose is a little bit going up, but it's the same. The lip falls the same way, lower lip. So this is a perfect match, but it's a really easy case. Now in here, you can see all the case at the same time, how we prepared the surgery and how we finished. But this one is really nice. This is open bite, preparing and finishing. So this is a very fast way to show the patient the beginning and the end, the middle, to show a patient or to show a colleague or to show another patient that looks similar and wants to know what is going to happen with the treatment. Here, a close bite, one maxillar, really easy. We expanded here in surgery, so it fits. But let's go to another patient. This is still is an easy case, but it's a very beautiful case. There's this patient with a really flat face. It's really fat. It needs volume here. Class 3. So we need to advance the maxilla. The arts are okay. There's nothing to do here. A little bit here, a little bit there, but nothing strange. This is the smile, really ugly. So we prepare for surgery, aligning, doing everything. See the lower arch, it's arched right now. It's not a square. The upper arch is good. Nothing strange here. So let's prepare it. This is the only case that I'm going to do this again, but it's so amazing. 1 Mississippi, 2 Mississippi, 3 Mississippi, 4 Mississippi, 5 Mississippi, 6 Mississippi, 7 Mississippi. In 7 seconds, it's almost done. It's incredible. I spent so many minutes in my life doing this in the bigger and then refinement. I still don't believe it. That's a little bit refinement. Even the soft tissue. I have to say that it's not always this good, but it's really funny that it's open a window saying, sorry, we couldn't do it better. We really are teaching the AI to do it better, but it couldn't be perfect. There we are. Molars are really difficult even for humans. I don't know how they do it. But yeah, they're almost there. Everything, yes. Save it. And let's start deciding what we're going to do to this case. Here we have it. In this case, we found out that the lip is going to get 3 millimeters longer. This is where the lip stays when it's in repose, when you don't do nothing to it. And this is the lip when you are smiling. So it's not really bad. It could be a little bit lower. We don't care if it gets 3 millimeters longer, because it's going to get to a really normal state here doing nothing, and here with a little bit of gingiva showing whenever it's mild. So we like it like that. Here, this is an okay. We don't have the nose measurement. The case is really simple. There's no canting of the plane. So the straight thing, or the thing that we want to do in this case, is to do an high left, so that it can have a lot of more volume, add a lot more volume in the middle third. That's where the patient is needing here some volume in the cheekbones. So let's do it. And that. Maybe. Yeah, I think that's perfect. A little bit that. I look at the orbit and the eye. If that fits and this fits, it's only rotating, moving a little bit, but it's almost there. Here in this patient, what we were trying to do is advance a lot. Here we have it. This teeth, it's going to close a little bit. It should be a little bit there. There we are. And let's do the refinement that we know this lip is going to get like 2 or 3 millimeters longer. And a little bit thinner. Safe treatment. Let's call it 1. And more. It's almost there. I forgot to lower, to raise a little bit the nose. Here, the morphine is only the profile. It doesn't show the volume that we gain. But let's see what happened in real life. It fits. Maybe I was a little bit, I took too much for the lip. It's not going to get so thin. But I think it fits. That's how I like it. So to show a little bit of the case, because it's really good, the final result. This is what we have. we have to do the contrary, the overjet, go to negative to have it really the teeth within the bone. And this is the end result. From this, see how the gingiva, the gum is going down because of the position of the teeth. We correct it, and that's good. The middle third, it's a lot better. Let's show it like this. I think it's amazing, this program. From the beginning, profile. And from the end profile. See how the volume of the highlight force. And this patient came 5 years later, and the gingiva was stable. Let's show it here. How the occlusion it gets even better, and it's as pretty, even prettier than we left her. So let's go to the next case. Let's start going. This patient no, I mean this one. He came like this, too young. We knew it was too young to treat it. We told him to go home. We checked out that it's fine. But 6 years later, this is what we have. And this is the start of our treatment. This is what we start doing. We prepare for surgery. The class 3. Here it's clear, the class 3, that we have to protrude the maxilla. So let's see what we see and what we decide to do. We find this patient, it's going to get 3 millimeters longer, the lip, and it's really low. We want this relation of teeth with the lip to be higher. So that's why if it's going to have 3 more millimeters, the lip is going to go here and it's smiling here. And it's a smile of a 70 years old, but not a kid smile. See, it shows a little, not much. We have to get more showing the teeth of the upper arch. That's why we decide not only to advance, but to get down, to gain showing of the lip, of the teeth. The nose, it's cut here, but it's going to do a little bit of movement. It's in the limit. We noted that with 5 millimeters of advance, it's going to get a little bit up. So we are taking it to the limit. But we are lowering the back end so that it's not so much. It doesn't pressure so much to the nose. Let's do it. Hey. Oh no, I know what's happening. No, I don't want this one. I want this one in a big trace already. There we are. There it fits. This fits. Yeah. There it fits a lot better. So with this patient, we decided to do monomaxillar to advance 7 millimeters. But lowering from the front and raising from the back. Okay. The nose already got up, so I'm not going to touch it a lot more. But it's going to be a little thinner. Yeah, kind of there. I had a lot of problems with this. In this case, I tried it. There's more fit. See, I had problems with this. The nose is not, it's not round, it's not like with bumpy. And the lower lip too. But it almost fits. It's a good prediction. It's planning correctly. More or less what we want to do, what we know is going to do, and what really happens. So it's there. It's there. Maybe the problem is me, that I don't touch the buttons how I should do. But let's go to another case. We have many cases, and these are just the beginning. This one, it's a really nice case. Look the bite that we have. But look at this. We have the midline, upper midline to the right and lower midline to the left. So this way that I found to do a really straight line. But instead of doing B-maxillar surgery, we decided to help us with elastics here to here so that we correct both midlines at the same time. And when the upper midline is corrected, go to surgery. Ask to the surgeon to add a mini screw in the fourth quadrant so that we can end correcting the lower midline after surgery. Let's show. This is what we have. So here we corrected only the upper midline. The lower, it's still wrong, and we know it. But instead of doing B-maxillar, it's an easy way to have the bed of orthodontics with a mini screw and the best of orthodontic, correcting both things at the same time. Oh, again, it's this one that I have. We have prepared. This is fine. This fits. Oh, sorry. I didn't show you what we were planning to do. The upper lip is going to gain 4 millimeters, and she has really low one. So we have to descend the maxilla. We have we need the advance for the class 3, but the nose is not going to react so much. So we do whatever we want, we advance in, and then descend as we wish. So let's go to the treatment again. And let's do the treatment. Treatment was advancing 5 millimeters and lowering 2. The lid is going to change. Yes. Yeah. It's going to get thinner, and the nose is going to raise. It's more. Animate. Oh, it was good. This morphine, I'm sure it might be good. I don't know how to do it better if the bubbly is a problem. But the lips are almost the same. The nose is almost the same. So we can say that WEBCEPH did a good job. But it's cool about this case, how it got out from here. Already surgery, but we are pulling and pulling and pulling and pulling the lower midline. You can see clear here. But we are still correcting the lower one with this huge mini screw that the surgeon put it because we wanted it. It was planned to have chin surgery at the end, but the patient didn't want it. She thought she was pretty enough. He had really good bite. a little bit of asymmetry in the chin, but from the beginning she was so happy. From what it came, what she got, only monomaxillar. That it's easier, it's safer, it's better for her. This patient, another class 3, let's go a little bit faster. Class 3, we need volume in the middle of the face. We need volume. And as before, we do a clockwise change of the occlusal plane so that the high effort is going to push more bone up there and give the volume. So let's go here. The lip is going to get a little bit elongated, and the relationship already is good. What do? We compensate the 3 millimeters going to get longer with extending the maxillar. We need the advance for the class 3, but as I was saying, we raise in the posterior to do a clockwise rotation of the occlusal plane so that the high effort, it gives a lot more volume right there. Well, let's do it really fast. So it's in here what we want. I think that fits pretty nicely with the beard and everything. Okay, so we had 6 millimeters of advance. Two millimeters lowering, but impacting 3 millimeters there. So let's do a lot and do 2 down and 3 up. And the mandible is going to come there. We knew in this patient that the lip is going to get a little thinner, as always. And the nose a little bit higher. I think this is my bubbly problem. I don't know how to touch this so that the nose is not bubbly. More or less. So let's morph it. And let's see what happens. Again, it fits. If you do what you are supposed to do, it fits. It's a really good planning tool that can help patients to understand what we propose to do in surgery. So loving WEBCEPH, loving it. And this, I want to show this case because genetics. This is what they were doing in another clinic. Class 3, everything, but the painful thing to see. This is included, and this is supernumerary, and they were not going to treat it. So he came to our clinic. In 5 months of treatment, we took this one out, we extract the other, and told him to wait. Told him to wait because we have to finish the growth. So whenever he came, in just 5 months, because it was already aligned, we took him to surgery. Let's see what we proposed to surgery. Again, the lips is going to get 3 millimeters longer. He has really high lip relationship with the teeth, so we don't care. We have to advance for the class 3. But if you see in these lines, we show the canting of the occlusal plane. That's why we lower this side and we raise this other side. That's how we compensate. And this is the midline of the teeth. And whenever you compensate, they're going to get better. We do a high effort again, but this is where this tool is so good. There was something there that I didn't show you on purpose. Maybe a little bit here. This. There it fits, I think. So we want 8 millimeters of advance. We need a whole bunch with these patients. And we find well, let's do the morph and see. It's a huge lower third. Okay, let's reduce it a little bit with a chin surgery. See, it's getting better. Okay, well, let's do refinement. We know the lip is going to be thinner. With a little bit the nose. This at the end was 7 millimeters, maybe a little bit more. And a little like here. This is the final result. Let's see if it fits. Oh, I raised too much to the nose. Lips, they are bubbly, but the planning is correct. The planning, it fits here, the angular here, the angle here too, the volume, the distance. And if I wanted to show this case, it's because of the relapse. Genetics are stronger sometimes. This is where we prepare. And this is how we finish the case. Genetics was still winning. The fit is nice. Volumes are nice. But he went to study to United Kingdom, I think. And he came that we needed to treat it again. But that's a good thing of mini screws. Only in the lower arch with braces and mini screws pulling, 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 pulling. We managed to correct and finish the case again. +1, +1. So good for the WEBCEPH that predicted good surgery, and good for mini screws that corrected the relapse of the genetics. This is a strong case. Let's see if the WEBCEPH can do this. This is what it came to the clinic. There's need for space everywhere, in the upper, in the lower arch, because the posterior are mesallicized. We have to take them back. We have to gain space. This is a canine, and at least it's in the mouth, because there's the other one, it's included up here. So this is temporal teeth. Class 3, and we decide to treat it not the easy way. Why easy way? But with mini screws in the 4 quadrants and pull everything back to gain space for this canine, to gain space for this canine, and then surgery. So from that chaotic mouth, we have space for this canine. This canine is already there. Lower arch, it fits everything. And this is only a matter of time to take it to place. So we start planning the surgery. Lower lip is going to get 3 millimeters longer. The relationship, it's a little bit high and smiling, but it's not so bad. So we do advance and we don't get up or down the incisors to keep this relationship. In class 3, we always try, or if we can, we try to give more volume here. So that's why we raise the posterior. And we prepare the chin surgery, because in here, not in the WEBCEPH, we see that there's fault, there's no volume here. Yes, I know. This one. Oh, there's no. I thought I had everyone. Oh, really fast. See, that's the message. I'm sorry, I couldn't do it better. The anecdote in this case is that he's a twin Vitaldent. Well, I don't know how to pronounce it, but he has a brother that it looks exactly the same. His brother didn't like the option of surgery and was treated with Damon. We finished first with surgery and all this space found out for everything that the brother and was a little bit jealous at the end. See, this is crazy. I think there's one and there's the other. We have it. Safe treatment. I don't know the sleep, but he thought it was here. I think that fits. Six millimeters of the lines. And the mandible fitting there. With a little bit of a mark down here. Three more millimeters of flip. And a little bit thinner. The nose is out. Oh, two out. Well, we don't look at the nose. There's nothing I can do. This is too nasty. And I don't know why it didn't close the lips there. Let me try. Closing lips. No. Even worse. Well, this is not a good example. I'm sorry. Yeah, it's there almost. I'm sorry for this. And now we want to show you this patient had class 1 molar and canine in both sides, but his father died when it was his age because of apnea. And look the thin airway he has. So we kept the class 1 canine and molar, but we advanced everything. And what we did, the real trick here, is that we anti-clockwise the rotation of the occlusal plane, so that that's going to get even more airway. Let's do it really fast. But I have it. Hmm. I don't know this nose. This is small. This feet. This feet. I think there's a problem of this line. So the treatment with this one, it's 6 millimeters to the front of both to keep the class 1. But if we do this, lowering 3 millimeters in the back, this is going to open a lot back here in the airway. Just a little bit of counterclockwise movement of the occlusal plane. Just a little bit. We knew in this patient, lips are going to get a little bit, just 1 millimeter longer and thinner. I think WEBCEPH did a great job right here. It looks exactly the same. Very good tool, WEBCEPH. I'm amazed. But I want to show you what we did with the airway. Incredible how much it can open. This is the initial airway, and it's 3 times bigger. And it's this trick to open the airway. The relationship is the same, class 1, but you see the difference. We have another patient of airway. He came to us because of apnea. But this patient, he had something to do this. He had class 2. It's not perfectly class 1. And here we say it's class 2, skeletal class 2. Already treated with braces, but you know. So really fast, let's go. Lip is going to get a little bit longer, and the relationship, it's really high. So it's better if it gets a little longer. This line is like this, going up, because the lip is doing this. So if we get the incisors up in here, it's going to follow better the shape of the lip, and it's a lot more aesthetics. So this is raising in the anterior. We are going to try to get better this relationship and this shape of the lip. advancing 7.8 millimeters. And again, we are going to lower from posterior to anti-clockwise the airway. This is something that we miss in WEBCEPH. Let me finish this. What do we miss in WEBCEPH? To do the treatment with this airway line to see how much we're going to get it. When we move the mandible, only the anterior airway line is going to move. So if we could do it at the same time, it would be a lot easier, but let's do it really fast. 7 millimeters protruding, going down 2 millimeters and 1 up. So this is what we plan to do. Mandible to class 1. Look how much we are going to get the airway open. A little bit of longer lip. Thinner and longer lip. And not much of the nose. More thin. Let's compare with reality. Well, yeah, it's almost there. Really good tool. WEBCEPH is really good tool. And then to finish, I'm going to jump. I've been showing too many patients already. Well, just to show. This patient had this bite, so we have to do the class 3. I'm not going to do the treatment, but just show that he was singing in opera. He was scared of doing the surgery so that it could change or he could not sing or whatever. We were treating the class 3, leaving a class 1. But if you see we didn't do it on purpose, but we gave a lot more space here because of the class 3. And they upgraded him. He was a small singer in opera and got to middle or even higher. Because even if when we don't try to open the airway, we can do it. And you have to treat it for class 3, but now if you know the trick of counterclockwise, you can do it on purpose. There, see, if we knew, we could have even get better in here. And just to finish, let me show some cases that the 2D is worthless. If you show this to a patient or to somebody or to a colleague, they're going to think that it's not a very big treatment, but really it is. 2D, we still use it, but the future is 3D. We have been using it for a little while, for many years now. And 3D is not going to take out the 2D. I mean, we are going to still do I know here. We are going to still do this. This is not going to end, but then we have to transport it to 3D. This is really the refinement that you do in 3D, the good thing, the cases ending correctly. But this is not going to end. So WEBCEPH it's needed already for now. And this case is even special, even more special, more difficult. Because this is a vertical and horizontal asymmetry of the mandible. This is one of the most difficult cases that we've done in this clinic. And the surgeon was Dr. Colmenero. That is the panel that it's going to come right now. But I want to show first one. How we finish the case. And this is muscular. It came 4 years later. And the result is what it came and what we ended with. But if you do the profiles, as I was saying, it seems as if we did just a little bit here, but not much. When the problem was real asymmetry, vertical asymmetry that the 2D couldn't diagnose. So well, I think it's. I've been showing many cases. I don't know if anyone has a doubt or want to say something. Hello.
Thank you. Thank you for the great lecture, Dr. Salgado.
You're welcome. I'm really nervous. Normally, I'm not so. Go ahead.
Okay, so it was really useful and it's meaningful time for us and to me either to be able to see the practical surgical case analysis in step by step using WEBCEPH. So okay.
I see there are questions in the chat.
Yeah. And there's a panel who participated at today's webinar. So I think we can have some discussion time with them.
Yeah.
Dr. Sorry.
May I present them? Well, I achieved 2 panelists that they're the best of the best of the best. They are in the top 3. Well, they are the top 3 in Spain. And the orthodontist is one of the first orthodontists doing orthodontic surgery in Spain. And it's my mentor, it's my boss, and it happens to be my mother. And she's shouting from the floor saying, no, I don't want to speak. I don't know how to say it in English. Say things about the questions in the chat, but not about me.
Yeah. Dr. Marina Poblacion, you can share your screen and also Dr. Quesada Colmenero.
Marina
Could
Poblacion,
you,
go.
yeah, could you please share your, turn on your video?
And César Colmenero, it's also one of the best in Spain.
Sorry.
The surgeon of Spain and maybe Europe. And they work together so many times and they do many cases. This is one of the César Colmenero's cases. And I think, I'm not sure, but it was one of the most difficult mandibles to cut. The treatment was difficult, but my mother is back here saying, "Oh,
Really? So, Dr. Marina, you can share your screen, or you can turn on your video and ask him the question. And also, Dr. Quesada, you can ask him, or if you have any question or an opinion.
Yeah, my mother wanted me to show you how difficult this was. Do I answer some of these questions?
Yeah, actually, we have some questions from the chat box. Okay. There's one question.
Hello,
Which
I'm here. Hello, I'm here.
Hello, Dr. Marina.
I'm here, but my English is quite poor. I would rather have my brother speak for me. Then we have the privilege of living the beginning of the digital age. How it has changed our life. This change has even come into surgical prediction for adult patients. But I found the morphine are not adapted to the Mediterranean population. Between the north and the south of Europe, there is very important difference in the shape, in the face. Nordic population is blonde, blue eyes, and very, very small nose. And we have big nose and also a very large and aquiline nose and very large lips. We can do forward movement of the maxillary movement very, very big, but also we run the risk of excessive elongation and flattening the upper lip, spoiling the smile. And I don't find any morphine program to predict that. Even I trying and also buying a very, very expensive program, and I decide to go back to the prehistory of the digital era and continue the seeding. After exploring the soft tissue and measuring the lip, I decide the amount to the forward movement of the maxilla and how I level the occlusal plane, the maxilla occlusal plane, if clockwork or counterclockwalk to get the smile. But I have to tell, in case of an important counterclockwise movement in order to increase the airway, I performed an open bite with orthodontic procedure in the mandible that performed the movement, the big counterclockwise movement to get an increase of the air weight. Okay, now I decided that some years ago, and now I'm very happy because I don't want to move down the posterior maxilla plane. That is a movement very relapse. And no, this one, I do occlusal movement, a leveling of the mandibular plane with a very, very big open and we can do the counterclockwise in the surgical procedure without moving the mandibular maxillar plane. I don't know. Well, in short, no morphine for now is perfect for Mediterranean people. I think we have to decide how much millimeter and in which direction we want to change the smile and the face of the patient. And in this moment, when you have this measure, you can sit down in front of the computer and not the opposite. I don't know what I want, but the computer are going to tell me, no, you have to go to the computer with some measure already done. This is my resume. Okay.
Thank you for the good comment.
May I add something?
Mm-hmm.
Are you seeing my screen still?
Yeah, we are seeing your screen now.
Together with what my mother said, that this is how we measure in the patient how the nose is going to react and how the lip is going to elongate. This distance is a little bit less than this distance. That's the question it's asked there. But my mother.
But you can show after surgery, Jorge. You can show the next picture, this patient after surgery, the new nose is exactly the same that we predict.
We can show how.
No lo he puesto.
Yeah, here. So how the lip is going to get thinner and a little bit longer. But we can go to a patient that eats a lot more. Let me see. Here. In this one, if we compare this lip before and after surgery, it's a lot longer. Maybe here we can see it better. It's longer, a little bit thinner, but you can see it because of the pushing of the maxilla that it's a lot for the more advanced.
Okay, Dr. Quesada, is there any question that you want to ask Dr. Jorge Salgado? Hello, Dr. Colmenero?
Can you hear me?
Mm-hmm. Yeah, you can hear you.
Yeah, well, I have to appreciate the tremendous work that Dr. Salgado has done, and I'm impressed. And for me, I have been working with both for a whole bunch of years, so I don't have much more things to do. So only to congratulate to the panelists and also to congratulate to WEBCEPH for the good work that you're doing.
Thank you. And it was also a very meaningful time to me because I am orthodontist, so the distance moved when I'm simulating treatment is smaller than in the case of surgery. So I was able to confirm the problems that were not natural in the simulation of around the lip areas. And because AI of WEBCEPH is mainly trained with the data of South Korea, so there's a big difference in the nose height in detecting the landmarks around the nose area. So therefore, it seems that the landmark detection results of the nose area tend to have low accuracy. So it's a meaningful time. I think I have to increase the number of the data set to increase the accuracy of the AI of the WEBCEPH. And I want to introduce the panel from the South Korea, Dr. Jang Min-seok from the South Korea. Hello, Dr. Jang.
Hi, nice to meet you.
Nice to
Thank you
meet
for a great lecture, Doctor. It was very informative and interesting topic. And thank you for using WEBCEPH in your cases. Thank you. Yeah.
Okay, then I'm going to share my screen now.
You're welcome. We offer all our cases so that you can run the AI in Hispanic or Mediterranean cases if you want.
Thank you. Okay. I'm sorry. There are some more questions that I received via the chat box. I'm going to share some of the questions to you. And said that which are the advantages of closing the spaces and retracting the anterior teeth by using coil springs? Can you answer that?
Coil nitty springs. The nitty, I love
Yeah.
it. It gives a force for so much time, and it's a low force. And you just have to compensate with the arch to have a little bit spare, the curve, and it closes things really, really fast, slowly, but continuously. Not like with stainless steel, that it's jump and stop, jump and stop, jump and stop. Nitty, it's always pushing, and it's incredible. And if you have a mini screw at the back, it moves them really, 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 really fast.
Thank you. And some other attendees asked that if there's any plan for WEBCEPH to support the PA-SEP analysis. I'm going to answer that. We are planning to add that feature too. So it might take a bit of time, but we are going to add that feature in the future. And for the amount of moment card for nation. And Dr. Ashfaq Alam asked that the WEBCEPH predict can WEBCEPH predict the amount of movement required for orthodontic surgery? Actually, there's no limit in the amount of the distance that each object of the part can be moved. So probably there should be some limit in the distance of the movement, but currently there is no limit yet. And,
so the distance, you have to see it in the face. You have to think, what do you want to meet? What do you want to get? And then with the WEBCEPH, you can see how it's going, what it's going to do. So it helps you to refine the quantity of movement that you decide in a patient.
Okay, and WEBCEPH X have prepared something as a sign of gratitude. It is a certificate of appreciation, Dr. Salgado. We are really impressed by your effort to share your valuable knowledge with the world.
Thank you very much.
Well, Dr. Salgado, do you have something to say to the attendees before ending?
Yes, thank you very much. I'm sorry, I was really nervous in my English, but I enjoyed it a lot, sharing all that I know of these cases and trying to give all the anecdotes and tips that I could give with these cases.
Yeah, I also hope that I see you in real world, not in the virtual world. So
Yeah, I went to
Okay.
Korea.
yeah, I want to visit
I know
your
it all.
country too. Thank you very much. And we will end today's webinar at this point. It was a meaningful time for me and to all the members. Thank you everyone for attending today's webinar, and special thanks to Dr. Jorge Salgado and all the panels today. I hope everyone's safe and healthy until we meet in our next webinar. Bye. Thank you, Doctor.
Thank you.
Thank you, Doctor.
Thank you.
Bye.
Bye.